research. I'm Susan Marchinosi, Assistant Professor of Mathematics at Harvey Med and organizer of this year's conference. This conference series is unique because its topic varies from year to year, and it was started to expose faculty and advanced undergraduate students to cutting-edge mathematics, and also to foster collaborations between the Claremont mathematics community and the participants of the conference. Recent topics have included enumerative combinatorics, scientific computing, mathematical biology, and geometry, algebra, and phylogenetic trees. And next year's conference topic will be on nonlinear analysis. Over the years, this conference has grown to attract participants from across the nation, and we warmly welcome you all to Claremont. This growth could not have been possible without the support of an NSF grant for the last 3 years and from the Harvey Mudd College Office of the Dean of Faculty. This conference could also have not been possible without the support of the mathematics department, Suzanne France, our administrative aide, who has been a godsend throughout this process, and also Michael Maka and Raymond Allen and the audiovisual department, HMC College Relations, dining services, and facilities and maintenance. We thank them all for their hard work for making this conference possible. Mathematicians and operations researchers have a unique role to play in solving the problems of society. Our ability to reason carefully, to think analytically, and to distill complex problems into tractable models that can be analyzed and communicated can have significant impacts on policy debates. It is for this reason that this year's topic of public sector operations research is particularly compelling, and why I'm especially thrilled to have the speakers that we'll have today. While applied math is sometimes abstract in nature, each of our speakers has engaged in extensive interdisciplinary collaborations to create models and solutions that were actually implemented. The talks we will hear today will demonstrate the importance of interdisciplinary work in solving societal problems in public health, bioterrorism, infrastructure design, emergency response, and the environment. So if I could draw your attention to the schedule just for a few logistical issues. So following our first speaker, there will be a poster session in Galileo Foyer. We have several postdoctoral fellows, PhD students, and Harvey Mudd undergraduates presenting their research, and I'm sure you'll all enjoy discussing them and learning about what they've been doing. Then we'll follow that with a second talk, and at 11:45 we'll break for lunch. If you've pre-registered for the conference, which would be evidenced by a pre-printed name tag, then we invite you to join us in the Hoke-Shanahan Dining Commons for a buffet lunch. And then there might be additional spots available if you registered the morning of. If you're an HMC or 5C student and would like to join us for lunch, then we invite you to join us on the upper level of the Hoke-Shanahan Dining Commons, but we ask that you please go through the normal lunch line. And the conference will reconvene at 1:30 p.m. and we'll have 2 afternoon speakers, an afternoon poster session, and we'll conclude the conference with an open discussion about future directions in public sector operations research. This is an opportunity for all of you to chime in about what you think are important problems for operations researchers and mathematicians to be looking at. And so if you have any topics that you'd especially like to discuss, feel free to jot them down on a piece of paper and hand them to me over the course of the day, and I'll make sure that they get brought up in the afternoon session. Okay, so without further ado, I'd like to announce our first speaker. Margaret Brandeau is Professor of Management Science and Engineering at Stanford University. She holds a BS in Mathematics and an MS in Operations Research from MIT, and a PhD in Engineering Economic Systems from Stanford. She is an operations researcher and policy analyst with extensive background in the development of applied mathematical and economic models, and a distinguished investigator in HIV. In 2001, she won the Pierce Scala Prize from INFORMS, the Institute for Operations Research and Management Science, which recognizes research excellence in the field of healthcare management, for her work entitled Optimal Investment in a Portfolio of HIV Preventive Programs. Professor Brandeau has also received a Presidential Young Investigator Award from the National Science Foundation, her department's Outstanding Teaching Award, and she holds a patent on a method for operation assignment in printed circuit board assembly. Professor Brandeau has published numerous articles in areas of applied operations research and policy analysis, and has co-edited several books. She's also served as principal investigator on a broad range of funded research projects. Her HIV research focuses on the mathematical and economic models to assess the value of different HIV and drug abuse interventions, both in the US and abroad. Professor Brandeau's talk today will describe examples from past and ongoing OR-based analyses of public health policy questions, and she will show us how, by approaching public health from an OR perspective, a little help can go a long way. Ladies and gentlemen, Professor Margaret Brandeau.
Thank you, Susan, and thanks so much for inviting me. You know, as I started to think about this talk a little while ago, what I was going to say, and at that time, I went to a teacher conference for one of my sons, and the teacher said, John, you're a very popular and charismatic student at this school, and what I want you to do is use your powers for good and not for evil. Well, my son wants to be a comedian, so there's a lot of using the powers for evil. But anyway, I realized that what I want to talk about today is basically using our powers for good, or more specifically, using our mathematical powers for good. And in particular, what I want to talk about is, well, as the first speaker of the day, I thought it would behoove me to just talk very briefly for a moment about the difference between public and private sector decisions. Examples in public health of why we really need analysis. Then I'd like to talk about 3 examples from work I've done on methadone maintenance treatment, HIV treatment in Russia, and hepatitis B treatment and screening and prevention in the United States. And for each of these, what I'd like to tell you is how we identified this problem as being of interest, what kind of analysis we did to solve this problem, or to at least analyze it, what we found out in our analysis, and then how we're trying or did influence policy. And then finally, I'd like to conclude with some lessons I've learned about trying to work in the public sector using OR. So how is public policy different? I hope you can see that picture. That's Steve Jobs. It looks like he's at Mac Expo 2005, January 2005, and he's standing there with a sales figure of how many iPods Apple sold in 2004. So that's private sector. Public sector. This being start of the presidential elections, I thought this would be a good picture. This is George Bush with some of his advisors. So I think they're having an Iraq War briefing. So how is public policy different? Well, you may think that public policy is different because you have to wear a suit, you have to have a lot of advisors, and you can't make decisions on your own. Well, that's sort of partly right. So one thing in public policy, it is true, we generally have no single decision makers. So if you think about applying operations research to company problems like I'm Hewlett-Packard and I wish to optimize my global supply chain, very often you can get to the point of a single decision maker. It's like the buck stops here. And that's just not necessarily always true in the public sector. Of course, profit maximization is not the objective. Very often, a lot of other factors come in. Political factors, social, in healthcare, social factors and ethical factors tend to play a huge role, legal factors. So the objective is not always that clear what it's supposed to be. Of course, this may be true of other problems, but a lot of uncertainty about outcomes, particularly in public problems where you don't know how people will behave or what will happen. So I think that for all these reasons, there's a great need for reasoned and quantified analysis. In public health, here are a few examples. When I go to the doctor, you know how you're sitting in the waiting room, and I'm really not making this up. Recently, I had 2 magazines to choose from, Ferret Fancy or Ladies' Home Journal. So I chose Ladies' Home Journal. And a very typical kind of article. You pick it up and you read about some mother who says, my child had a very rare disease that was not diagnosed. And my child almost died, but we saved my child. And in all these articles you see, if we could just prevent one person from getting this disease, it will have been worth it. Well, that's not necessarily true because we don't have enough money to prevent all diseases. So that's one example. Another example, it turns out that in the HIV epidemic, which as you probably know is the worst pandemic ever to face the world, it's enormous and growing. And what's happened recently is we've had a huge push for treatment. In developed countries such as the United States, it's pretty routine that people get HIV treatment if they're HIV infected, and that's great. They tend to live normal lifespans and very good. And in other countries, particularly in sub-Saharan Africa, people don't get those drugs. So there's been a huge push by the World Health Organization and Gates Foundation, other foundations, to get people into treatment. But it turns out, so there's been a lot of scale up in the treatment, but it turns out that of the people who were enrolled in treatment worldwide last year, I don't know, 600,000, 2.4 million other people became infected. So we're putting a lot of money into treatment and not a lot of money into prevention. So something's wrong here. And these are just a couple of examples. When I thought about the need for analysis in public health, I could have filled up page after page. So just put some dots in there. So there's really a need for analysis. And as I've kind of highlighted, we'll just never have enough resources. And you know, one of the things that we study in operations research, a lot of the problems we look at is problems fundamentally of resource allocation. Well, that's exactly what most of the public health problems are about, is we don't have enough resources. We need to figure out the best way to use our limited resources. So to do that, and I just thought I'd tell you just for a moment or two how in public health we think about problems. We use an economic framework. Typically we do what's called cost effectiveness analysis, where you look at, well, how much will this intervention cost me? And not just the intervention, but the downstream healthcare costs that may be incurred and lots of other costs. And what kind of health benefits will I get? So it's kind of like the military bang for the buck. Although the bang in this case is health benefits, and we tend to measure it in life year gained, or maybe quality adjusted life years gained. So you can measure other things as well. But the idea is that because there's no single decision maker, we really want to evaluate possible public health programs based on how they might compare to other things we do, how they might compare to other things we want to do. So we want to use a common metric, and typically it's cost per life year gained or cost per quality adjusted life year gain. That's just sort of looking at the quality of life of what happens from your intervention. So that's a little bit about cost effectiveness analysis, and that is where the mathematical modeling comes in. It's to figure out, okay, well, if we were to have this prevention program, this treatment program, this vaccination program, what kind of costs might we expect? What kind of health benefits? That's where the mathematical modeling comes in. And so what I'd like to do is tell you 3 examples of problems that we've worked on. So as I mentioned, the first one is expanding methadone maintenance treatment in the United States. I call that one, are we just substituting one type of addiction for another? Second one, how to allocate incremental HIV treatment funds in Russia. And I call that one, why should we waste scarce rubles on injection drug users? And you'll see why I've got these names in a minute. And the last one, preventing and treating hepatitis B in the United States, which I call, I don't want to tell one more 30-year-old he's going to die. So let me tell you a little bit about the methadone maintenance treatment. Are we just substituting one type of addiction for another? Now, it's not often we have a warning in a math talk, but I have to give you a warning here. Okay? And that warning is that there's a gruesome picture coming up. So if you're squeamish, avert your eyes. I'm kind of used to this picture by now, but you may not be, so seriously. Okay, heroin addiction. I just want to tell you a little bit about heroin addiction. So this is a picture of a person shooting up heroin. Heroin's an opiate. It's highly addictive. People who inject heroin become addicted. They have to inject about every day, maybe sometimes twice a day. I don't know if you can see that picture too well, but all kinds of comorbidities. It looks like this person has some kind of horrible staph infection at the injection site. So not a good thing. What are some of the problems? Well, people who are heroin addicts tend to not be able to hold a job because they're high and they're addicted, tend to have to steal to support their habit. A lot of social problems, can't take care of their families. High death rate from overdose, and as I kind of highlighted, also comorbidities. It turns out that the untreated street injection drug user, heroin addict, has a 3% chance of dying. So 1 in 33 will die every year from heroin overdose or the comorbidities. So very risky and not a good thing. But another thing about injection drug use, and in particular heroin use, is it's the ideal way to spread a number of viruses, including HIV. It can also spread hepatitis B, hepatitis C, other things, but HIV, huge problem, and it turns out that it's an ideal way to spread the virus. In New York City, in the late 80s, we went from having almost no injection drug users infected with HIV to having 40%. So rapid, efficient spread. So that's a serious, serious problem. And then, of course, they can spread it to their sex partners or their children if they have children. So it's not a good thing for many, many reasons. So what could we do about it? Well, we could certainly put injection drug users in jail. In many countries, that's actually what's done. Or we could, try to get them to stop using drugs. There's so-called detox where you lock the person up and say, you'll be fine in 5 days, and then you send them on their way, and terrible withdrawal, and actually not very successful. Inpatient treatment, put them in a hospital, help them get weaned from the drugs. Residential treatment where you add support services like help them get a job. And then the last one is just what I want to talk about, which is substitution therapy. And the idea here is that you're going to, instead of the person having cravings for heroin, you're going to give them a drug that replaces that craving. But this drug won't make them high. And that's what methadone is. So methadone. The way methadone works is the person who is the heroin addict goes every day to a clinic to get a little cup of methadone. Methadone is a controlled substance because it turns out if you take enough of it, you can get high, but if you take the right dose, you can't get high. And so this replaces the addict's craving for for heroin. So they go, they get the methadone, and they're not high, they can function. There's a couple drawbacks, though. They have to go every day to a clinic because it's a controlled substance. And it's in a particular class of drugs that can only be given in a single dose under a supervised setting. So they have to go every day. And so in a way, they're kind of, instead of being addicted to heroin, they're addicted to methadone. So that's what methadone is. As you might imagine, many programs are publicly funded because injection drug users tend not to have health insurance. So we tend to have state and federal governments pay for this. In the United States, very limited capacity for this. There's enough for about 15% of injection drug users. Long waiting lists, and not available in all states. And I might add that we have, for many nonviolent offenders, a number of states, including California, have mandated drug treatment instead of jail time. So we've got even greater demand for methadone and other types of drug treatment. So how did I get interested in this problem? Well, I thought I'd throw in a Rudy Giuliani quote. Again, this being, a presidential primary time. Rudy Giuliani, mayor of New York City, as you may know, very outspoken person. Well, when he was mayor of New York City, he got wind of the fact that New York City has the largest privately funded or publicly funded methadone program in the world. So New York City has many, many injection drug users, and they're paying for them all to have methadone, or many of them. And he just thought, why am I doing this? So this is a quote. It was on the front page of the New York Times in 1998. We're just substituting one type of addiction for another. Drug abuse treatment is the moral and decent approach to curing addiction. So that was his position on this. So that was kind of interesting. Then there were all these headlines on the front page of the New York Times. I just took these all right from the New York Times. Mayor wants to abolish the use of methadone. Methadone, is it a cure or an addiction? Few successes to back the mayor's methadone limits. So a lot of hue and cry about his idea of cutting off methadone. So interesting. But then at the same time, the director of our Office of National Drug Control Policy, also known as our nation's drug czar, who at the time was General Barry McCaffrey, a retired Army general, he actually came out and said, you know what, I think the federal government should expand methadone programs. So on the one hand, you have a very highly visible politician with a huge methadone program in his city saying methadone is bad. On the other hand, you've got the drug czar saying methadone is good. So we thought, well, why don't we try to do some analysis of this problem? So we decided we'd look at the costs and benefits of methadone maintenance treatment. I worked with the health economists at our local VA hospital. Turns out the VA system nationwide treats a lot of injection drug users or former injection drug users, and with a PhD student in our department who's now a faculty member in OR at University of Western Ontario. So let me tell you just a little bit more about methadone maintenance. So some of the benefits. The person who goes into methadone is not going to be using drugs as much because they're now taking methadone every day and not injecting heroin. And thus they won't be transmitting HIV to other people if they're not injecting drugs. And then very often they can keep a job, and so a lot less social problems and costs associated with that. On the other hand, methadone maintenance treatment, which I've abbreviated here MMT, it's costly, about $5,000 or $6,000 per person per year. And it turns out when somebody gets into methadone, you immediately screen them for HIV. If they're HIV infected, they're going to get all those drugs, again, paid for out of public budgets. They're going to get a lot more health care than they might have. So there's other increased costs. But more than that, methadone is not a perfect intervention. People who are on methadone, it turns out they actually do inject drugs, just not as often. They might inject heroin once a week. They do share needles, just not as often. In addition, the average stay in methadone is about 2 years, and 90% of people leaving methadone go back to untreated heroin use. Only 10% so-called graduate. So we need to look at what are the costs and benefits. I hope you like the animation. Our grad student did that for me. I don't know how to make it go the other way. That's beyond me. But anyway, so you have to ask yourself, well, I just told you it's a costly intervention. It removes individuals only partly from circulation because they're still injecting and sharing. And only 10% are actually being cured. So how could that ever be cost effective? Well, to answer this, we need a mathematical model. You probably knew that was coming. You need a mathematical model. So what did we do? Well, and I'm just going to tell you very briefly the kind of model we used, but we developed a dynamic model of the spread of HIV. We looked at injection drug users, non-injection drug users, and injection drug users who were in methadone treatment and not in treatment. It's basically a nonlinear dynamic system. It's a compartmental model. I'll talk about that in a minute. We discretized it, put it into an Excel spreadsheet. And actually this is interesting, the actual making of the model was not the really hard part. The actual hard part was getting the data. So we made the model in about a couple weeks. Getting the data took us about a year. So we had to go through all the medical literature. And this is very important if you want to convince people of the accuracy of your analysis, that you have some data as much as possible to fill out your model. So collected a lot of data, and then we used the model to figure out, well, what is the cost and what is the effectiveness of such treatment. So just a brief overview of what our model is. I'm not going to show any equations, but just to give you a flavor of the kind of analysis. So, you know, I believe in back-of-the-envelope models as much as possible. Sometimes that envelope gets really big, but try to keep it on the back of an envelope. And this one is pretty much on the back of an envelope. So we looked at injection drug users who are not in treatment, that's the top row, who are in methadone treatment, and those who don't inject drugs. And then we looked at those who are not HIV infected, that's the first column. Those who are HIV infected but asymptomatic, that's the middle column. And those who actually have symptoms have AIDS, that's the last column. So it's a compartmental model, so everyone in the population is in one compartment or another, and you can sort of guess I'm going to have 9 compartments. So here's the people who are uninfected. They're not HIV infected. So the top row, those, they still inject drugs. The middle row, they're in methadone treatment. The bottom row, they don't inject drugs. Well, we can have disease transmission happening in this dynamic model. So uninfected people can become infected. And the way infection transmission occurs in epidemics, it's nonlinear. It's a function of the number of people who are not infected multiplied by the number of people who are infected. So that's where the nonlinearity of our analysis comes in. And then people who are asymptomatic can eventually progress to AIDS. So in each of those categories, whether you're an untreated injection drug user, you're in methadone, or you don't use drugs, you can progress according to the, if you get HIV infected, you can progress to AIDS. Now, we're of course looking at trying to get people into methadone treatment, so we can have transitions into methadone treatment. People can leave methadone treatment. They can either go back to untreated injection drug use. Remember I told you 90% do that. Or, quote unquote, graduate, 10% do that. People can spontaneously start using drugs or stop using drugs. Those are those vertical arrows. And then from all these compartments, people can die. So what we did is we wrote down a set of simultaneous nonlinear differential equations. And for those of you who are students, when I was a student, I took dynamic systems. And it seemed interesting enough. I don't know, rabbits and wolves, predator, prey. It seemed good. You know, but I didn't really have any sense of the usefulness of it. And it wasn't until I started looking at epidemics that I thought, wow, nonlinear dynamic systems, that is so good. You can really model things. And it turns out that if you're looking in broad population groups, models of this type actually can really represent epidemics well. One more comment I want to make here is that the whole field of epidemiology uses nonlinear dynamic systems of this type. But the difference between epidemiologists and operations researchers is epidemiologists, and I hope I don't have any epidemiologists here, epidemiologists tend to just say, well, what will happen? Operations researchers say, what action can I take, and what will be the consequences of that action, and what's the best action? So we're using ideas from epidemiology, but we're overlaying a decision framework. So anyway, we had a model like this, year and a half to collect the data, learned a lot about many gruesome things. What did we find out? Well, we used the metric of the cost, the net present discounted cost per quality adjusted life year gained. So in this previous picture, I believe we estimated that people who are not injection drug users have and are not HIV infected have a quality of life of 1. It's like perfect health. It's not really true, but perfect health. People who are injection drug users automatically have a decrement of 0.2, so their quality of life is 0.8. People in between maybe have a quality of life of 0.9, and then we had quality multipliers for the stages of HIV. So for each year of life lived, we adjusted it by a quality multiplier. So what we found out is that if we would expand methadone treatment in the United States, it costs about $8,000 to $10,000 per quality adjusted life year gained. Well, if you compare this to many other health interventions, things we routinely pay for, that is dirt cheap. So to get back to my original question then, how can a costly intervention that removes individuals only partly from circulation and results in only 10% of people being cured ever be cost effective? It can, and our dynamic model allows us to find that out. So it's very cost effective. It's a good thing to do. And interestingly, because we have a model, we can do lots of sensitivity analysis. In fact, when I sent this article into a journal, one of the referees said, you could argue that injection drug users' lives are worth nothing. They're useless people. So why don't you give them a quality multiplier of 0? So I did that. Another referee said, you could argue that injection drug users, they just have a problem, but they're as good as you and I. Let's give them a quality multiplier of 1. So I did that. And it turns out it didn't change the analysis at all. It's still a good thing to do. But that's a good thing about a model. We can vary different things. So very cost effective. And because we had this dynamic model, we could actually find out, even if you think injection drug users are horrible criminals and all, there are actually a lot of benefits the non-injection drug users. If the injection drug users aren't getting infected with HIV, then their sex partners aren't. And those are people who don't inject drugs very often. So benefits to other parts of the population. And so our conclusion is that barriers to methadone, which it's actually illegal in 8 states, are actually restricting access to what really is a cost-effective medical intervention. Now, I can't tell you whether it's the moral and decent approach to curing addiction, but I can tell you it's cost-effective. So that's what our analysis can tell you. So we publish this both in a public health journal and in an OR journal. What have we found out since then? Well, some areas have expanded methadone. I think people do realize it's a good thing, or it can be a good type of drug treatment. Other states have had budget cutbacks, a couple headlines. There's still long waits. These aren't actually that recent, although I have more recent as well. So kind of a mixed bag. I think people realize it's good, but when state legislatures are making their budgets, sometimes drug treatment is one of the things that gets cut. So that's our methadone study. Next one I want to talk about is what I call, why should we waste scarce rubles on injection drug users. So for 10 years now, I've had funding from National Institute on Drug Abuse to do basically OR and economic modeling of various ways of preventing and treating HIV. And basically through a series of circumstances, we received an additional grant for we didn't actually apply for it, we received an additional grant to do work on HIV prevention in Russia. So we said, okay, we'll go think about that. So we traveled to Russia, and our graduate student, Elisa Long, who's here, was actually one of the ones who spearheaded this project, and she has a poster about it. But we got together with a number of policymakers in Russia to sort of find out, what are your problems? What are the most important problems? So here's what's going on in Russia. So as you may know, after the collapse of the Soviet Union in Russia, a lot of problems ensued. Some people have become very wealthy, but some people have not. Life expectancy in Russia for a man has gone from about age 70, about 15 years ago, to age 55. So a man in Russia, a baby who's born in Russia now, a male, has a life expectancy of 55. That's on a par with many countries in the developing world. So why has that happened? Well, after the collapse of the Soviet Union, the economy kind of collapsed, the healthcare system collapsed, and another thing, big problem with HIV. So this is a picture of an HIV patient in Russia. I don't know how well you can see that picture, but basically, this patient's getting nothing but palliative care. You know, no hospital gown. Looks like his father and his uncle are there with him. Really nothing given to the person. They've got a bed. That's about it. So a lot of social problems. So HIV in Russia, it turns out it's a very rapidly growing epidemic. In fact, it's the fastest growing HIV epidemic in the world. Russia has a population of 140 million people. It's going down by 1 million a year. It's going down because of the decrease in life expectancy, not just due to HIV, but alcoholism, suicide, unhealthy lifestyles, lack of health care. So life expectancy has decreased, and the birth rate is below the replacement rate. And so the epidemic's growing rapidly. In the last 10 years, they've gone from pretty much no one being HIV infected to 1 million people out of 140 million. So a lot of very rapidly growing, and it's fueled by injection drug use. It started in the Baltic states and in the heroin routes in southeastern areas of Russia. And again, as I mentioned, very efficiently transmitted that way. So it's fueled by injection drug use, although now they've begun to spread it to their partners, and well, to prostitutes and their partners, so it's getting more into the general population now. Very minimal funds for HIV prevention and treatment. We've actually been to Russia 4 times, and on one of those trips we met with HIV physicians at hospitals, and they just said, I have nothing to give the patients. I can treat 20 patients, and there are 2,000 who need it. So very, very minimal funds for treatment and for prevention as well. I mentioned that HIV treatment, which we abbreviate HAART, highly active antiretroviral therapy, that this is a really good thing. It extends life, and actually has another benefit, that it reduces a person's infectivity. So it's doubly good. It's good for the individual and good for all their contacts. But very limited access. Very few people are getting this treatment. But what we've seen, and I mentioned that there's a scale-up of such programs worldwide, same thing in Russia. A lot of international agencies, World Health Organization, Soros Foundation, a lot of them have channeled treatment funds to Russia, and they're trying to now scale up treatment for all these people who are infected. So I mentioned we traveled to Russia, and we asked people, well, we talked to people who run needle exchange programs, drug treatment programs, HIV clinics, clinics for the prostitutes, all kinds of people. And we basically found out that one of the most pressing policy problems they face is, if we're going to scale up HIV treatment, who should we give this treatment to? Because we're never going to have enough. Again, resource allocation. We're never going to have enough money to treat everyone we need. In this project, I worked with a colleague who's a professor of medicine at Stanford, Elisa Long, our PhD student who's here, and has a poster on this, as well as a young woman who is a physician from Russia and has a master's in public policy, and another young woman who's an expert on HIV in Russia. So we had kind of an interdisciplinary team. So we're looking at who should receive treatment. And right now, about 1% of the non-injection drug users receive the treatment, and no injection drug users receive treatment. Why not? Well, because they're criminals. In Russia, injection drug use is criminalized, and you can hear this all the time from any government official. Injection drug use is illegal. We're not going, and in fact, we're not going to treat these people. They're doing something illegal. And then even people who say, well, okay, we will treat them. Well, they're not going to take their medicine anyway. They're drug users. So these are some of the reasons why. So we thought, well, gosh, if the epidemic is being fueled by injection drug use, seems like there ought to be we ought to at least look and see, is it worthwhile treating these people? So we looked at 3 broad types of strategies. The current strategy, which is you don't treat injection drug users. Another strategy, the polar opposite, where you treat only injection drug users. And then another one was sort of untargeted, where you just basically treat anyone who needs it and don't ask about whether they're a drug injector. As before, we used a dynamic model. In this case, we also had to model the effects of treatment. As before, it's in an Excel spreadsheet. Is that right, Elisa? Yeah, Excel spreadsheet. We like Excel spreadsheets because that's the only thing I can understand. Collected a lot of data. And then we used our model to figure out, well, what would be the costs and health benefits from each policy. Now, Elisa has a full poster on this that will be out there later, but just an overview of, again, a dynamic model. So we have injection drug users. Some, they're not infected and they're not treated. They could become infected, but they're asymptomatic and not eligible for treatment yet. You have to the HIV has to progress enough till the person's eligible for treatment. So they're not being treated. Then they're at a level, I've sort of abbreviated this, but they're at a level at which they're eligible for care. And then they could progress to AIDS. The last 2 boxes there, so people can progress through these. The last 2 boxes, people could receive treatment. And same thing, then we looked at, well, people could move into treatment if we expand treatment programs. And then we had the same thing for non-injection drug users. And although I haven't shown it here, there's lots of linkages between injection drug users who can spread the virus to their sex partners who are not injection drug users. But again, using concepts from epidemiology, combining them with more OR concepts of costs and benefit, and looking at alternative decisions. So that was the model. And people can die from any compartment. Again, I would say you could fit this on the back of an envelope, so back of the envelope model, sort of. So what did we find out? So what I've got here is a graph of cost versus quality adjusted life years gained. So for each strategy, including the status quo where 1% of the non-injection drug users receive treatment right now and no one else, that's our status quo. And then for each of the strategies, we plotted, well, in the population over like 20 years, including future things that could happen, what is the incremental cost of our policy? And this includes not only treatment, but all healthcare costs. And what kind of quality adjusted life years are experienced in the population? So if you look at this, when we think about cost effectiveness analysis, you could think of the efficient frontier, which is sort of coming down from the upper left. Anything that is in the convex hull here is efficient. So here, in this case, this is the convex hull. Well, you could have a line to untargeted as well. I didn't show that. But so going from the status quo to any of the other policies, the best one to do would be just to target injection drug users. You gain the greatest benefit for the least cost, because that has the steepest slope. That sort of, we knew that in advance, but really that's a completely unpalatable strategy. There's just no way that people in Russia are going to say, oh, we won't treat non-injection drug users, we'll just treat injection drug users. That would never, ever happen. So we eliminate that. It's good to know, though, but it's never going to happen for social reasons. And then this is our efficient frontier. So what this says is that you really should not target the non-injection drug users, which is kind of what would happen if they implicitly followed the current policy and just treated more and more non-injection drug users. You should have an untargeted policy. You shouldn't discriminate against people who are injection drug users. Just whoever needs treatment, treat them. So that's the findings of our study. The current strategy is really the worst one of not treating injection drug users. It's the least effective and least cost effective. It's a very misguided strategy from a public health point of view. We assumed an additional cost for the injection drug users, like $500 a year, to make them take their medicine. Remember I said that they won't take their medicine? But we spoke to a number of physicians and other people who said, well, you know, if we spent $10 a week to supervise the person and have them come in, they'd take their medicine. So we had an additional cost. So even with that additional cost, very cost effective. Well, one more thing I want to say about the previous slide. So I've written down, if we would implement this new policy, we're going to expand treatment and just to everyone who needs it without regard to injection drug using status. The cost per quality adjusted life year gain is $1,800. Now, we have to ask ourselves, is this a good or a bad thing? It turns out that the World Health Organization has developed guidelines saying that if an intervention costs less than 2 times the gross domestic product, it's highly cost effective. This is well below that, below 2 times Russia's gross domestic product if expressed in dollars. So highly cost effective. Anyway, so our conclusion here is that when Russia expands its treatment as they're doing, they really need to go after both injection drug users and non-injection drug users. They should not discriminate against the injection drug users. From a public health point of view, it's the worst possible thing to do. So that's our finding. We published this in an AIDS journal. So one of the things you got to do in public health, there's no one decision maker. You got to work with, try to influencing policy. So we published it in a major AIDS journal. We got our article translated into Russian. And we recently visited Russia in May to present our results and disseminate our articles. We didn't quite throw the article out of airplanes, but it was close. Everybody we met, would you like to read a really interesting article? So that's kind of how we're trying to influence policy, is meet with as many policymakers as possible, give them an article that's published in a respected journal, translate it into Russian, get people to change their opinion. I can't say yet the extent to which opinion has changed, but we're still working on that. So a little bit of an update. You know, Russia sort of now at least will acknowledge that HIV is a serious problem. Obviously still got problems. Russia has finally acknowledged HIV is a problem and started to increase funds for HIV prevention and treatment. So we'll see what happens. Okay, my third example, which I call, I don't want to tell one more 30-year-old that he's going to die. And this one is about hepatitis B. And in fact, the way I got interested in this project was a transplant surgeon from Stanford, a liver transplant surgeon, came to me and he said, you know, I'm really concerned about the problem of hepatitis B. I have transplanted so many livers in young Silicon Valley engineers from Asia, and many of them I have to tell them, you're going to die. You're too far gone with hepatitis B, you're going to die. I don't want to tell one more 30-year-old he's going to die. I'm wondering if you can help me think about how we can, from a public health point of view, reduce hepatitis B prevalence in the United States. So I said, well, I don't know anything about hepatitis, but I know about math modeling. So that's how this project got started. So let me tell you a little bit about hepatitis B. It's a blood-borne viral infection. It's spread basically by either birth or by sharing of blood. So it could be household contact. A little kid could use the brother's toothbrush that has a little blood on it or something like that. It can be shared by sexual contact or by sharing of infected needles. People who get infected with hepatitis B, I'm going to talk about this in a minute, many people can fight the virus off, and it's the so-called resolving the virus, but some people become chronically infected where the virus, your immune system cannot overcome the virus. Of the people who are chronically infected, 25% will die from liver disease. And that's generally a very bad thing. In the general United States population, there's about 0.4% prevalence, which is about 1.2 million people in the United States have hepatitis B virus, chronic hepatitis B infection. But among Asian and Pacific Islanders in the United States, the prevalence is 10%. So the transplant surgeon was saying to me, we need to reduce this health disparity. We need to know what can we do about this problem. It can be prevented by vaccination. We have a vaccine for it. It's routinely recommended. If any of you have children, they go for many, many shots. And I know Professor Jacobson's done all kinds of interesting work on the different shots and how you're going to get all those shots into the kid. But one of the things they get is hepatitis B, routine. So it can be prevented by vaccination. Can also be treated with antiviral drugs, interferon, and many other antivirals that have recently been developed. Not cured, though, treated. So immunization is routine in the United States, but it turns out if you look at Asian and Pacific Islander children in the United States, 1/3 are not vaccinated. Every year, 40,000 legal immigrants enter the United States who are hepatitis B infected. Of these, half are from Asia. So basically what's going on here is that in Asia and the Pacific Islands, and by Asia I also mean India, so very broadly Asia, very high hepatitis B prevalence, very low relatively low vaccination rates. We have a lot of immigrants coming in every year. So even though we're trying to vaccinate lots and lots of children, we have a fresh flow of hepatitis coming in every year. So 10% of 10% of Asian and Pacific Islanders in the US are infected. So what can we do about that? So our project then was to look at catch-up screening and vaccination policies for adult Asian and Pacific Islanders in the US. So it's anybody who did not get vaccinated as a child. Should we vaccinate them now? Should we screen them first and see if they're infected and then vaccinate them? Should we just go ahead and vaccinate them? So just basically among the adult Asian and Pacific Islanders. And as I mentioned, I worked with a surgeon at Stanford as well as one of our PhD students from our Management Science and Engineering department. So we looked at several policies. First is universal vaccination. It's just, you're an adult Asian and Pacific Islander, here's a vaccine. $20 a shot, you have to have 3 shots. So it's, as vaccines go, it's cheap. So you could and it won't hurt if the person has been vaccinated. So you could just vaccinate them. You could screen the person and then see if the person is chronically infected, you could treat them. You could treat those who are chronically infected and those who are not infected yet and have not ever been exposed, you could vaccinate them. Or you could do a variation on that, which is called ring vaccination, which is if someone is found to be infected, you could say, well, what about your wife and your grandmother who live in the house with you, and then go vaccinate them if they're not infected. So that's something that's commonly done to control infectious diseases. So those are the policies we looked at. So how did we evaluate these policies? We basically made a Markov model of how the disease progresses in individual patients, and then we considered a cohort of patients. So unlike the previous 2 analyses I talked about, this is not a transmission model. This is just people who either are or not infected with hepatitis. We didn't have a dynamic model. We just assume a constant chance of acquiring hepatitis infection. Again, good old Excel spreadsheet. Collected data on this, lots and lots of reading of the medical literature, and talking to a lot of surgeons, because as I say, I don't know anything about hepatitis. Now I do, but to learn about it. And then finally, we used our model, and as before, look at costs and health benefits. So here's our Markov model. So we have some people who are susceptible. That is, they've never been exposed to the virus, so they could be. When a person's exposed to hepatitis, they get what's so-called acute infection. So the virus is in your body, and you either can or can't fight it off. If the person can fight off the infection and so-called resolve it, then they become immune. Otherwise, oops, I seem to have a timer on here. Otherwise, so I better talk faster. Otherwise, they get chronic infection. If they get chronic infection, the liver could start deteriorating. We have an enzyme we measure, alanine aminotransferase. So they could start, the liver function could start going down. And then if it goes down, they could get cirrhosis, which is scarring, liver cancer, or go from cirrhosis to liver cancer. And when you start getting into this region, you might have to have a liver transplant. And that's, in fact, what my friend does. Oops, go back, stop. Anyway, and then the other thing, which I've got over here on the right, is treatment. So people who are eligible for treatment, this enzyme has become elevated, which means their liver function's decreasing. You could get them in treatment, and then they might have the so-called durable response, and it may or may not fail. So that's treatment over there, durable response. Anyway, so this is our model. From any of these states, you could die. Then we looked at different policies. So here's universal vaccination. So that's just anyone who doesn't seem to have any symptoms of hepatitis, just vaccinate them. So that would basically, the only people it would benefit is people who are susceptible and have never been infected. Then that'll make them immune. So that's the effect of universal vaccination. If you screen and you try to identify who's infected, in other words, who has chronic infection, then that'll increase eventually. You monitor people with chronic infection. It'll eventually increase the rate of people going into treatment. So hopefully get more people into durable response. And then screening, treatment, and vaccinations, kind of both of those. You'd see who's not infected and not exposed, and you'd vaccinate them. People who are chronically infected, you'd treat them. So these are the different types of policies we looked at, and you could either have regular or ring vaccination. So another one of these X versus Y axes, cost versus quality adjusted life years gained. So these are the different policies. So here's the status quo, where people are not getting anything except treatment if they become sick. And then you could see, for example, universal vaccination. It costs a lot of money and gains almost no health. And then we have our various policies up here: screen, treat, and vaccinate, screen, treat, and ring vaccinate. We can draw the efficient frontier here. It's not quite a straight line. The incremental cost of going from the status quo to screen, treat, and vaccinate is $36,000 per quality adjusted life year gained. And going to screen, treat, and ring vaccinate is $40,000. So what we found out then is that universal vaccination, which in advance seemed to me like a pretty good thing, let's just find these people and vaccinate them, turns out it's really not. And I didn't realize this going into the analysis, and that's why analysis is good, because it turns out that adults who become infected with hepatitis B have a very low chance of acquiring hepatitis B chronic infection. Like 99% can resolve the infection on their own. So when you're going to adults who aren't infected with hepatitis B, they're not going to get it anyway. But where the real health benefit comes in is from treatment. We have all these great antiviral drugs. They're expensive, but they're effective. So we can use our model to figure out, we have that Markov model, we can figure out, is it a good or bad thing? So it turns out it is a good thing. Ring vaccinate's more expensive than regular vaccination because we assume it's like $100 to find each contact and contact them and get them in and then vaccinate them. A little bit more expensive, but definitely more effective. So our conclusions from this study is that universal vaccination is not cost effective. Really, you want to screen and treat, or screen, treat, and ring vaccinate. The health benefits of these things are really coming from treating infected individuals. I never would have thought of this going in. Originally going into this study, I was thinking, we want to prevent hepatitis. This is what we want to do. But it turns out that what we really want to do is find out who's infected before it's too late and save them from dying. The other people, if they're not infected and they're adults, they're not going to get infected. We also, because we have a model, we can look at what if we had less than 10% prevalence. It turns out, even if you have more what we call intermediate prevalence, it's still cost effective. So that's a good thing to know, that we perhaps should look at other populations in the US that have intermediate levels of prevalence. How are we disseminating our results? We are publishing it in one of the top medical journals. We've been working with the Centers for Disease Control and Prevention on this, sort of showing them our analyses and seeing if the assumptions we used were consistent with what they know about hepatitis and the epidemiology in the US. We sent them our spreadsheet, because remember, it's Excel spreadsheet, so they can actually use it. So we're disseminating our results to them. Update. So our work's going to be published next week And we found out that the CDC is actually going to change its screening and treatment guidelines as a result of our analysis. So we're very excited about this because I feel like it's not often that as an operations researcher you can say, hey, the work I did might have led to somebody not dying, or at least somebody not dying from a terrible disease. Everyone's going to die, but that's another story. I think Professor Barnett made that clear last night. Anyway, so this is an example of a study we did where we actually got the people involved to change their guidelines. And in fact, now we're working on hepatitis B catch-up vaccination in China. So the transplant surgeon I work with is Chinese, and he's got a lot of contacts with the very high government officials in China, and he's running some immunization catch-up programs, so we're doing cost effectiveness of that, and we're going to go to a hepatitis B summit and speak about OR modeling in China in May. So that's my third example. Now, what have I learned from all this? Well, I really like this. This is the final page of one of my children's books I used to read to them when they're young. The book is called Tough Cookie, and it's about this detective. I don't know if you can tell from that picture, he's a chocolate chip cookie, and he's trying to figure out who's stealing the cookies from the jar. It's a bad guy named Fingers. And so anyway, you know, the whole book goes on, and he finally figures out who Fingers is, you know, and the girl, the mall, says to him, you're one tough cookie. You don't learn fast, but you do learn. And that's kind of how I feel about my adventures in OR modeling. I may not always learn fast, but I have learned a few things. So let me share with you what I've learned. So I think a successful public policy analysis, the first thing is you've got to have a real and important problem. I mean, I never really thought about this, but it's true. The analyses you do that turn out to be the best are ones that people really care about. And, you know, if you've noticed from what I talked about today, there are not any theorems in those papers. It's all about, here's a model, here's analysis, here's what we found out. So we just tried to focus on a real problem and figure out what value can we add. So I mentioned we went to Russia and we actually asked people, what are your most important problems? The transplant surgeon came to me with another one. But in every case, I think the successful analyses is the ones where it's an important problem that people care about. Another thing, in almost all the projects I've done, it's interdisciplinary collaboration. Since I'm working in public health, I don't know anything about hepatitis, or I didn't. I don't know a ton about HIV treatment, but I'm learning. So interdisciplinary collaboration is pretty important. Maybe one of my main points here is that it's really, well, I keep saying it's on the back of the envelope, and if you saw the paper, you might not agree with that, but the idea is that the focus has to be on trying to figure out what the best policies are and keep the model as simple as possible. Now, John Calkins from Carnegie Mellon actually put it very well. He said, use a medium complexity model to do your work. So not so complicated that, you know, it's completely unusual, but not so simple that it just won't answer the question. So use a medium complexity model, but then when you explain it to policymakers, use a simple model and no division. He says you can only use addition, subtraction, and multiplication, okay? So I don't know if I can do that, but anyway, really the focus is on identifying good policies. I think also generate just a few key insights. I mean, all the physicians I meet and a lot of the public health officials, they don't really care about OR so much. They just want to know, what did you find out? Why is it true? Now, some of the things I worked on, like the hepatitis, I really didn't know in advance that treatment was going to be the thing. But once I finished it and then was able to go to people and say, oh, wow, treatment, that's the way to go, then people would buy that because I explained, well, here's why, and it made a lot of intuitive sense. I got that intuition from using the model. So generating a few key insights, and often the model really leads to those insights. And then finally, very important, is to disseminate results to policymakers. Public policy tends to be a very diffuse process, so it's not like there's one decision maker, but nonetheless, if we want to influence policy, we really have to work on disseminating our results to policymakers in any way we can. In public health, this tends to be trying to publish in the top medical journals because doctors really, you know, if it's in a top journal, that's good, but other ways as well. So these are a few of the pearls of wisdom I've gained over the years. You know, I think my concluding comment is that public policymakers really need our help, and we have a lot to offer. So thank you. And if you're interested in any of thing I've spoken about, there's my website. Thank you very much. Yes.
Given that you've got all of this there and you've made your model, how do you get by or present through the skeptical viewers? How do you know your model's right, that you are modelling what we want the outcome is predicted? That's always the question. In physics or something like that, you can produce these sort of things, but how about?
Well, for example, in the hepatitis Markov model, what you do is you look at untreated patients, how many develop cirrhosis, how many need a liver transplant, and you see if that matches reality